The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. Glad to have you here. Appreciate you stopping by and listening or viewing the next episode of TMD Demystified. My name is Tony Urbanek. Today's episode has a unique little title to it. We're going to call it Click, 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 and TMD. For those of you who are familiar with the problem, you probably already know the general gist of the direction that this episode will take. Clicking of the temporomandibular joint is actually the very first sign, S-I-G-N, sign, that exhibits itself for people who have temporomandibular joint disorder. There is an awful lot to say about clicking within the temporomandibular joint. There is a tremendous amount of confusion from both doctors and patients alike regarding clicking of the temporomandibular joint, and I hope to remove the majority of those confusions within the next few minutes. So, first of all, let's start out with the prevalence of clicking. Clicking is almost pandemic in younger females, adolescent, early adolescent, middle adolescent females. There is no pain involved, and pretty much everybody ignores it. Now, clicking can occur anytime in life. It doesn't have to be involved in only adolescent females, but clicking, by definition, is nothing more, nothing less than movement of the meniscus or disc, which I call, within talking to patients, I call it the cushion between the ball and the socket. The cushion between the condylar head and the glenoid fossa is a piece of cartilage about the size of a nickel that's placed between the condyle and the glenoid fossa. It has a biconcave shape to it. In other words, it's concaved on the superior surface and concaved on the inferior surface, and moves along with the condyle as the condyle moves out of the fossa during the second portion of mandibular opening. So let me clarify that again for those who are not familiar with the anatomy, or a review for the doctors and a clarification for the patients, is that the condyle is the socket, the ball of the ball and socket, the glenoid fossa is the socket, glenoid fossa is the socket of the temporal bone, and the condyle fits in the glenoid fossa, and as the mandible opens, the first half of opening is a rotation around the condyle, and the second half is a translation of the condyle down the slope of the temporal eminence, and it literally drags the meniscus, disc, or cushion along with it down the slope of the temporal eminence. That's how the mandible works in the normal patient. Now, the clicking, which is almost always the first sign, whether young, middle-aged, or old, one of the first signs that patients recognize, make them aware of temporomandibular joint, and frequently it creates no pain, especially in younger people, and it's ignored. But clicking is not a good sign. It is definitely an indicator that there is something wrong with the temporomandibular joint. And by the way, TMD, or temporomandibular joint disorder, it is one disorder, not multiple disorders. And it is a singular disorder that it is created by damage to the temporomandibular joint, which in turn creates inflammation within the temporomandibular joint, which in turn creates all the symptoms. So, as a very quick review, TMD, which is defined literally as the list of symptoms created by the disorder, TMD should be defined, the proper definition of TMD should be defined as the list of symptoms, which are frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, a feeling of fullness in the ears, like you can't hear, like you've been in an airplane, you got water in your ear, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling, numbness, and various kinds of jaw locking. And actually, clicking is a variation of jaw locking. And clicking is intentionally placed on the bottom of that list of symptoms because you have to have some of that other stuff is going on before you ever get to the locking part of this. But again, the domino effect of the disorder itself is first you have to have damage to the joint. Damage to any joint is followed by inflammation. Inflammation within the joint. Inflammation is the body's response to damage in any part of the body, under any circumstances, and almost every disease. Inflammation is the body's response to damage. No different in the hip, the knee, the elbow, and the temporomandibular joint. There are three categories that damage the temporomandibular joint, and to my mind, only three. The first is bruxism, clenching and grinding over a long period of time. The second is acute trauma of various kinds. Any kind of traumatic injury to the jaw, the face, can damage the temporomandibular joint and create chronic inflammation. Most common is automobile accidents and whiplash injuries, well known for damaging the meniscus, excessive opening of the jaw itself, excessive extension of the mandible, which damages the meniscus, creates inflammation, leading to chronic inflammation. And the third category are functional malocclusions, where the bite, the occlusion, is so terrible that it overloads the joint. All three of those categories can be discussed or thought of as either acute or chronic damage to the temporomandibular joint, again, which in turn creates inflammation. And if the healing does not go on appropriately, then it turns to chronic inflammation, basically a different type of cell organization and different cellular responses in chronic inflammation, which in turn then generates each and every one of those symptoms that I mentioned. Now, getting back to clicking. Clicking is nothing more than the meniscus, disc, or cushion being loose. And it becomes loose under the influence of inflammation. Inflammation within the temporomandibular joint causes the ligaments that hold the disc in place to get loose. In a healthy joint, the disc is supposed to move a little bit and silently for sure, within the temporomandibular joint. But as inflammation takes hold within the joint itself, again, created by some kind of overload, some kind of damage of the three categories. The ligaments begin to get loose, and when the ligaments get loose under the influence of chronic inflammation, and when the condyle head moves in and out down the slope, that disc will begin to click, 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 but no pain is involved. That is one of the earliest stages, if not the earliest stage, of locking of the temporomandibular joint, but is almost always ignored because there is no pain. And again, occurs very frequently in young females. Again, why females? Because estrogen exacerbates inflammation. No, that is in the literature for 70 years. Estrogen exacerbates inflammation. So that is why this is primarily a female disease, 90% female, 10% male. It's all common sense. It's all in the literature. This is not rocket science. But today we're talking about the click, 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 click. So the next thing that occurs when the clicking is ignored long enough. Now that long enough could be 2 weeks, 2 months, 2 years, 2 decades. But sooner or later, if ignored long enough, the cushion, disc, meniscus becomes really loose. The ligaments become less supportive, and the click will be caused by the meniscus coming all the way out of the glenoid fossa socket, balls up into a little ball in front of the socket. Now, when the patient opens up, they get about halfway open. For a moment, they can't get past their cushion, which is sitting here in the front. They can't get past until the cushion clicks back. That is usually with a louder noise, more often defined as a pop, P-O-P, pop, and that is most likely to cause some kind of pain. But that happens occasionally and then more frequently. And when that is ignored significant amount of time, the cushion or disc, which is now balled up in front of the glenoid fossa because the ligaments that hold it in place are so loose, and now when the condyle comes down the eminence and bumps into the meniscus, which is balled up here in front, it can't get past it, and that is when we begin to have permanent locking. We call that closed locking. Basically, you're locking but partially closed, and that can be anywhere between half closed, 3/4 closed, to all the way almost completely closed lock, where the patient cannot open fully at all. But again, it all starts out with the click, 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 click early on, which is the earliest sign of temporomandibular joint disorder. Now, you can have other early signs. I mean, you can have headache or earache occurring before the click occurs, but most often, by my personal observation, doing consultations for well over 10,000 people, for sure, for absolute sure, I've done consultations for over 10,000 patients with temporomandibular joint disorder. One of the earliest, most significant symptoms are clicking within the temporomandibular joint. So that is the explanation of what clicking is, then leading to, quote, popping and instantaneous locking, which then leads to permanent locking. It is a progressive disease, and the only thing I can't predict is how rapidly it progresses. It progresses slowly in some people. It progresses rapidly in some people. A lot of that, I think, has to do with the type of insult or category of damage, whether it's bruxism, acute trauma, or the trauma associated with functional malocclusion. But all three of those are one way or another traumatic events, acute trauma or traumatic trauma that occurs over a period of time. So the clicking itself is a sign, not a symptom. Now, what's the difference between a sign and a symptom? A sign is what doctors look at or look for that are objective findings on the body of the patient that can be observed objectively by another. So clicking is an objective finding. It just so happens that it can be also determined subjectively, both subjectively and objectively, but it is classified as a sign as a objective finding, and clicking is an objective finding that can be heard by the healthcare provider, versus a symptom, which is a subjective finding, a subjective experience finding that is subjectively voiced or expressed by the patient themselves. So that comes into view, or very important when you're discussing with patients whether or not treatment is going to fix, improve the symptom. So, as I said earlier, there are 10 major categories of symptoms. There are actually others that I won't go into that are less common, but the 10 I reeled off were symptoms of temporomandibular joint disorder. But the clicking or noise, whether it be a click or pop, is actually a sign. And in the process of using a proper device and protocol, which unloads the temporomandibular joint and removes all the symptoms, each and every one of those symptoms can be diminished, decreased, and removed, but you can't remove the signs, this objective finding, which is click, click, click. Once the joint ligaments are loose on that meniscus, it's always going to be loose. Now, that meniscus, as the chronic inflammation percolates or increases, whatever you'd like to say, within the temporomandibular joint, that noise or noises within the temporomandibular joint can and will change characteristics, primarily variable on the amount of degenerative change within the structures within the temporomandibular joint, which certainly include the disc or meniscus itself, the disc between the ball and the socket, between the condylar head and the glenoid fossa. The disc can degenerate, but also the surfaces of the bone itself, the glenoid fossa and the condylar head, to the point where the noises change from a click, we talked about, to a pop, to a grate, to a grind, to a crunch. And then as those noises change, it's indicative of increasing degenerative change of the tissues of the meniscus and the condylar head and the coverings of the bone, the periosteum. And so those noises will change, but they always start out as a click, 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 which everybody ignores. But it is a bad indicator. On the other hand, if treatment is addressed early at the time of clicking, or at the earliest time of other symptoms like frequent or recurring headaches or that feeling of fullness in the ears, then the progression of the disease can be avoided, because all you're doing by unloading the temporomandibular joint with a proper device, emphasize on proper device, that is not a night guard, that separates the posterior teeth, which removes all the forces or loads on the temporomandibular joint, which allows the chronic inflammation to go away, which is connected, used with a protocol. You have to do it correctly. You have to use that device or tool correctly to allow the inflammation to go down. But if you start treatment before you start having significant symptoms, at the time where, as an example, the first sign would be clicking of the temporomandibular joint, you can avoid all of the other symptoms and never have to get into them. but you have to use the protocol correctly. The protocol would be, depending on age of the patient and number of symptoms present already, but the general protocol is 24/7 in the device, 24 hours a day, 7 days a week for 2 months, then nighttime only the rest of the patient's life. And all you're doing there is unloading the joint initially very quickly, and then over a period of time consistently, allowing the inflammation to stay away, to decrease to the point where it does not cause degeneration. It does not cause further ligament damage, loosening of the ligaments, which in turn would then keep the meniscus in more of a normal position. It wouldn't be loose, although once it starts to click, it's always going to click. Clicking is a sign, not a symptom. We can alleviate fixed symptoms, but not the signs. We can alleviate the subjective complaints, the subjective findings, the subjective symptoms, but the objective clicking, once it's loose, it's always going to be loose. Although the locking is a different story. Locking is a symptom. And as I've discussed many times before, the locking under the influence, when the chronic inflammation goes away, the synovial fluid, the lubricant within the temporomandibular joint becomes more lubricative, becomes more like a lubricant, and the meniscus then is able to go back into a more normal position just because the chronic inflammation goes away. Chronic inflammation causes the synovial fluid to get sticky like glue rather than its natural component, which is a lubricant like oil. So, as a review, it stands to reason, it is reasonable, logical, that more people, doctors should certainly be aware, dentists should be aware, physicians should be aware, convenient care clinic nurse practitioners and physician's assistants should be aware that clicking is not something that should be ignored within the temporomandibular joint. At the very least, patients should be aware that this is the very first sign of damage to the temporomandibular joint. You don't get clicking if there's no damage. I mean, if the joint is in a normal position and it is normal, that cushion disc meniscus will not make any noise. It's a bad indicator. And the healthcare providers need to be aware of that and advise patients. And then it's up to the patients to decide, do they want to alleviate future problems by using a proper device to avoid future problems. And that is a patient's decision. And again, it really has to be a patient's decision because no one can predict how rapidly a clicking disc will progress to a locking disc, which then will progress to a degenerative disc and degenerative problems within the joint itself. So that is kind of a brief dissertation about what healthcare providers and patients need to know and understand about clicking. Clicking is not something that should be ignored. Whether you act on it or not, I think, is more of a personal opinion or personal desire to avoid problems in the future. With that said, I'd like to invite anyone who'd like to discuss this with me or criticize. I'm available, Tony at tmjservices.net. Our website, which describes how to become a provider for the Urbanek device and protocol, because it's patented, FDA cleared, university studied, independent university study based on 3,000 patients with high success rates in the 90+% rate, as long as the patient will follow the protocol of alleviating the symptoms of temporomandibular joint disorder, singular disorder, which is created by chronic inflammation within the temporomandibular joint, but unfortunately, not the sign of clicking, click, 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 click. So that's what I have to say about TMD and clicking. I hope this helps. I hope this gives you some insight and doesn't get confusing for you. It shouldn't be confusing. There should never be a reason for you have to try to make a big deal out of clicking when you know exactly what it is and what it isn't. I look forward to our next episode. I'm Tony Urbanek, and this is TMD Demystified.